Good morning, everyone, and welcome to the 2021 Society of Cardiothoracic Surgery meeting. We're live online in this new virtual format. Hopefully, as things are getting back to normal, we'll all be able to meet up soon. But today and over the last year and a bit, the organising committee have put together this very exciting programme. We encourage everyone to get involved and make sure any questions that you put on the chat. We make this as interactive as we can, although we're not actually meeting in person. So first of all, I'd like to hand over to Giuseppe to introduce the first presentation. Thank you.
Good morning, everybody, and welcome to this first session of the meeting. And it's a pleasure and an honor for me to introduce the first speaker, who is Professor Giulia Veronesi. She's going to talk about robotic thoracic surgery. She's got a great experience as she's one of the pioneers of robotic thoracic surgery in Europe and in the world. She has got also a big experience in lung cancer screening, and it's going to be a pleasure to listen to in robotic thoracic surgery. Welcome, Giulia. Thank you very much.
Good morning to everybody. I'm Giulia Veronesi from San Raffaele Hospital in Milan. I would like to thank for this kind invitation, the meeting organizers. So we talk today about robotic thoracic surgery. We started robotic surgery at the end of 2006. After we realized that with low density program, we detected a lot of cases at very early stage of disease. And so the standard open surgery was an over-treatment for this. We also know that Vats surgery has important advantages for patients and represented a great step forwards the quality of life of these kind of individuals, with also a lot of data in terms of improved 4-year survival and lower morbidity compared to open surgery. However, we have some limitation of VATS, like lack of three-dimensional view, bad ergonomics, tremor amplifications, and counteractive movements. And so the introduction of the robotic technologies has been performed to overcome these VATS technical limitations, maintaining all the advantages of low invasiveness. And for this reason, robotic surgery has been embraced by a large number of surgeons in all different disciplines, with an important increase every year of the number of the procedures. And also, we can say that we could see a transition from open to robotic surgery, in particular in the US non-academic centers, where many open surgeons adopted robotic instead of VATS. And in fact, we can see here a stability of VATS procedure during the last years, while robotic increased from 1 to 18% in 2016. A lot of improvements, technological improvements, translate into some benefits for patients. In fact, we have in this series of high volume centers with more than 20 robotic procedures every year. So after the learning curve, complications and conversions were reduced in the RATS group compared to VATS group of patients. In this other paper, we can see a comparison of respiratory complications after robotic and open surgery in patients with marginal pulmonary function. And we can see that it is in this kind of patients that more benefit of robotic can be seen. So postoperative complication, were much lower in the robotic group compared to Vats to open surgery in the compromised patients. But also from the radicality of the surgery, we have important benefit. And we could demonstrate in this prospective study that compare video thoracoscopic surgery versus Vats in our centers, a larger number of lymph nodes sampled, both atelar, mediastinal level, and the number of stations removed. So this has been confirmed in our randomized clinical trial, the Roman study, Vats versus Rats surgery for lobectomies, where also we confirm a benefit in terms of lymph node dissection. We also think that more benefit of robotic can be seen in more complex cases. In particular, as you can see here, stage 3A disease had a very good survival curves after robotic surgery in this multi-center study, retrospective study, performed by Serfolio and other colleagues, including our group. And this is because of the radical lymph node dissection we can accomplish with this kind of technology. The fact that lymph node dissection is an important prognostic factor in lung cancer surgery has been also shown by this paper in case of segmentectomy versus lobectomy. If you consider all the population, the segmentectomy group had a lower survival compared to the lobectomy, even if very small cancers, less than 2 centimeters. But when you match patients according to the number of lymph nodes removed, you can see that the two survival curves are similar. So a more extensive lymph node dissection can be associated with equivalent survival between matched patients undergoing sublobar resection versus lobectomy. Also in this paper, you can see that in the segmentectomy group without lymph node sample, we have a worse survival compared to the group with lymph node sample. So this also confirms the role of radical lymph node dissection. And we know that robotic surgery can accomplish a very extended lymph node dissection at mediastinal and hilar level. According to the cost analysis, we compared robotic open and Vats surgery. I could see that we still have a good margin, 18%, for the hospital compared to the public reimbursement for a lobectomy, even in the robotic group. And this improving perioperative outcome and postoperative stay. The same data occurred in a paper published by the colleagues Ghulam Abbas in US on robotic versus Vats segmentectomy. And what he could confirm is that robotic was less costly compared to video-assisted thoracic surgery. In this paper by Jean-Marc Bast, the costs were higher, but in a similar, with good results in terms of reduced rate of conversions, postoperative stay, and major complications. So we have clinical benefits. The technique of robotic surgery and lobectomies in our center is here described. We have only 4 incisions without the 5th trocar for the assistant at the table, and the utility incision is done at the beginning of the procedure. This is different compared to other colleagues in US like Serfolio and Margileski, and we don't use routinely the CO2 insufflation. We also have an approach, an anterior approach to the hilum, very similar to the Vats approach. We introduced the concept of robotic segmentectomy in this paper together with Bernie Park of Memorial Sloan Kettering Cancer Center. So we conclude that robotic system, by improving ergonomic, surgeon view, and precise movements, make minimal invasive segmentectomy easier to adopt and perform. And here you can see how easy is the dissection of this small structure, segmental structure of the left upper lobectomy, left upper lobe segmentectomy. The vessels are clipped using hemlock, and the lymph nodes are here dissected, as you can see, using a hook. Then we have the dissection of the small bronchus and parenchyma. Similarly, we describe the use of indocyanine green to define this intersegmental plane in a very nice and easy way. We use the infrared light of the robotic camera. And for example, it's these patients with two lesions, one in the middle lobe and one in the S6 of the right lower lobe. We decided to perform two radical anatomical resection. So here you can see we started from the lobectomy, the middle lobectomy, isolation of the vein, of the bronchus, and of the artery. As you can see here, we transect the parenchyma and we perform and complete the middle lobectomy. After we isolated the pulmonary artery in the fissure, as you can see here, and we isolated the pulmonary vein of the segment here in the fissure always after resection of the artery, and here we dissect the bronchus, the segmental bronchus, and resected it. After this, the transition of the pulmonary vein of the S6 is performed using the stapler introduced through the utility incision, and here the intersegmental plane vision using the injection of indocyanine green. The indocyanine green should be injected after the vein and the artery, but in particular the artery of the segmental of the segment is closed. This is another case, a patient with a screening detected nodule in the right upper lobe, PET positive, but very centrally located, so difficult. We had to have a biopsy, so no preparative biopsy. We decided to do a diagnostic and therapeutic segmentectomy. So here the isolation of the artery in the fissure, here the isolation of the bronchus, always in the posterior fissure, which is checked using an endoscope. The bronchus is transected with a stapler, and then the injection of the indocyanine green with definition of the parenchymal stapler line and removal of the spacemen. Here I would like to underline the different approach to screening cancer in different eras. For example, the first is the description of NLST. You can see only 30% were treated with Vats lobectomy. In the Danish group, in Danish trial, thanks to the presence of Pedersen, we have 84% of minimal invasive approach. And in our trial, which is called SMAC study, we have a transition from the Vats to the robotic approach for the screen detected cancer. And also here you can see how the presence of the segmentectomy have been done in 1/3 of our screening cases in the SMAC trial, but no cases in other experiences. And in fact, we had very low rate of complications after surgery for screening cancer, 0% conversion, and only 3 postoperative days of stay in the hospital. But for a more advanced tumor, also we had improvement of the robotic system and approach, because you know that for N2 disease, there is no consensus for the Vats approach in this paper, for example. But with the robotic system, we have important benefit in terms of lymph node dissection, as said. So we believe we can be radical even in N2 and N1 disease, even after chemo or radiotherapy. And in fact, we demonstrated in more than 200 cases with stage 3A disease that it is feasible and safe. According to the overall survival, we we analyzed our oncological outcome according to treatment or clinical versus occult end to disease, skip metastasis versus no skip metastasis, but the only significant difference was seen in according to the number of positive lymph nodes detected at mediastinal station. And this is an example of a patient that underwent a right upper lobectomy after chemotherapy for a T3 and 2 disease, non-small cell lung cancer, and this kind of locally advanced disease. This is the CT scan after chemoradiotherapy with the important reduction of the size of the tumor, but persistent lymph nodes at the mediastinal level. So we started from the subcarinal lymph node dissection. As you can see here, we removed all the lymph node in a radical way. Then we moved to the right paratracheal region. Here you can see the superior vena cava, which is isolated. All the lymph nodes are removed. The azygos vein is transected, as you can see here. The lymph nodes are removed in a radical way from the trachea and from the superior vena cava. Here is the dissection with the azygos vein. And here is the lymph node dissection in the fissure. The lymph nodes are removed from the pulmonary artery in the fissure. And then the fissure is completed with a stapler introduced through the utility incision anteriorly. We removed other hilar lymph nodes in this way, and the small vessel is ligated. Then we continued the isolation of the hilar vessels and removal of the lymph nodes at the hilar level. Here is the isolation of the pulmonary vein, which is then transected using a stapler. And here the isolation of the pulmonary artery for the branch from the upper lobe, for the upper lobe, which is dissected from all the hilar lymph nodes that you can see here, very close to the artery, arterial adventitia. So then transection is done in the standard way using the stapler, and then the lobe is completed after the isolation of the bronchus here, right upper lobe bronchus. Clean margin were obtained. The other anterior fissure is completed with the middle lobe. And then the bronchus. Here the check of the ventilation check, and here the transection of the bronchus. Last, I would like to show you how we remove a very big lesion of the lung without the rib spreading. So we recently introduced this kind of technique to remove the large lesions from a subxiphoid axis, and this results in a very low postoperative pain. So patients go at home very quickly with no pain, thanks to this kind of incision. So to conclude, robotic surgery allows to extend surgical indication of minimally invasive surgery to more complex surgical cases like a major resection after induction treatment or atypical segmentectomy. It allows to obtain adequate oncological radicality to the improved lymph node dissection. And we have, of course, important benefit in terms of surgical trauma and quality of life compared to open surgery. So there is a diffuse awareness that robotic surgery will become the minimally invasive approach of the future. I would like to thank you for the attention.
it would be great if you could rate the presentation that you've just heard, which I think you'll probably all agree was excellent and very interesting. And then as we come into the sort of future presentations, I'd encourage you to submit your questions on the Slido application, because the Q&A session's at the end. Julia Veronese isn't going to be joining us for the Q&A session, but all the other speakers are. So I'd encourage you to submit your questions. And then I take great pleasure in introducing our next speaker, who is Professor Felix Hirth from Heidelberg in Germany. He's been incredibly instrumental in developing new endoscopic techniques, and he's a previous president as well of the European Association for Bronchology and Interventional Pulmonology. So he's going to talk to us about endoscopic interventions for emphysema.
Good morning. My name is Felix Hirth. I'm a respiratory physician from Germany, from Heidelberg exactly, and it's a great pleasure to be invited again to your annual meeting. And let's talk together about endoscopic lung volume reduction possibility for our patients suffering on chronic obstructive lung diseases. First of all, let me show my conflict of interest. All the companies I will talk later are on that slide because we developed a couple of those technologies together. And research without support from the industry is, at least in Germany, not possible. Why are we talking this morning about chronic obstructive lung diseases? This is just a recently published survey by patients suffering on lung diseases dying, and you see the green bars, these are patients dying due to COPD. So it's really the burden number one in respiratory, that patients developing that type of disease have a mortality rate which is really dramatic. So what can we do as respiratory physicians? You see, this is the development of the inhalers. It started with the short-acting betas in 1973, and the last development was the triple therapy, where we put all the different single components in one inhaler. But when you look to the shortenings, it's LABA, it's MAR, it's ICS. So there's not really a new drug coming for our patient. Actually, what we're doing is just combining what we have. But we're knowing that our patients have a high mortality rate, and when we look especially to those nice figures which have been painted nearly 100 years ago by our colleague Netter, we know that patients who developing the emphysema type are those who have really a mortality expectancy which is comparable to our patients suffering on lung cancer. And therefore, the idea was born: can we treat our patients suffering with obstructive lung disease endoscopically, doing something a little bit which you have seen in interventional cardiology? So are interventions the new options for our patients suffering on various lung diseases? I just have on that slide what actually everything is in use or under clinical research. So there are a lot of technologies for different phenotypes of obstructive lung disease. But coming back to the lung volume reduction story, so the patients who have really the highest problems of the disease due to the disease and the highest mortality rate, we know that our patients developing an emphysema are limited by the exercise capacity to the hyperinflation of the lungs. So therefore, the breathing mechanic cannot really be working anymore properly. So the idea was to reduce the size of the lung, to make this lung small again. And by doing the lung smaller again, we may hopefully can increase the exercise capacity by improving the breathing mechanics, and by doing that we can bring the patient back to a better quality of life and also change the mortality signal. There's a long story behind. It started with the surgeons. Copenhagen did the first, 1955. But unfortunately, they have had mortality problems, morbidity problems. So there was 50-year silence. And then the endoscopic technology came in our hands. And the first technique we have had have been the valves, followed by the coils, the glue, and the steam. And I will give you a short overview where we are today after nearly 20 years of development, minimal invasive technologies for our patient suffering on emphysema. So the longest and the best evidence we have for sure for the valves, we have nowadays published several larger randomized controlled trials showing that the valve in the right patient really has a lot of impact for those patients. So therefore, we have to select the patient in the best way. What we're doing therefore nowadays is a dedicated CT analysis, mostly done by software analysis offered from various companies. Therefore, we want to know, are there fissures between the lobes which are intact? How is the lung density? Where is the emphysema score the highest to pre-select the area we want to treat in the best way? So first of all, when the patient seems to be qualified, you have to undergo the CAT scan to get a detailed analysis. And especially for the valves, we have to know if the fissures are complete, which you see on the left side, or if the patient has an incomplete fissure situation, because we're knowing when we want to block the flow into one lobe and we have an incomplete fissure situation, there's a backdoor ventilation. It cannot work, so therefore we have to know, are the fissure complete? And for those, you can use the CAT scans. You see here nicely that on the left side, in that patient, the fissure seems intact. On the right side, there are the red space, there are incompleteness of the fissure. But we also can measure that endoscopically with a special balloon catheter, where we're measuring the outflow of the target lobe. And then you see in the upper part of that measurement the decreasing of the outflow signal. Then you know that is a patient who has a CV negative situation. That's a candidate. When you have a persistent outflow over minutes, we do not really have no flow, so we have to accept that the patient is not qualified for the valves. What we're doing in daily routine, we often combining that, so we're going for the CT scans. When the CT scan shows us by the QCT analysis a complete fissure, that means more than 90% integrity, then we're going directly for the valves. For those who have a little bit incompleteness in the QCT, we do the Chartis measurement before we put the valves in. And in those who have a no flow signal, they getting that, and others are not qualified. So these are data from one of the last publication from Jerry Kreiner. They have really showed that in a randomized controlled trial, when we doing that and we putting the valves in and we are able to reducing the volume, so when we are really able to reduce the residual volume, then all other endpoints going in that right direction. You're seeing the yellow lines, nothing happens. This was the control arm. But in those who really have had residual volume reduction, SGL2, 6-minute walk test, distance scoring, as well as FE1 have been dramatically improved. And we also can using the QCT stuff to see what we have done. You see here the volumes of the lobes in the upper part, and then you see how the lobes are shrinking when you put in your lung volume reduction devices. This is the evidence of the valves, of the Zephyr valves, and when you look, compare that to the lung volume reduction surgery trial, the NET trial, we really can say we can achieve the same amount of lung function improvement, the same winning of meters in the 6-minute walk test. The St. George Respiratory questionnaire is dramatically improved. And we have similar complication rates. Like the surgeons, when you look to the pneumo rate all over, when you really look to the pneumo rate in detail, and that is what we're doing. From a long-term perspective, the endoscopic technologies are way less correlated with longer complications than the surgical technologies. But we have to accept that the pneumo is one of our major problems when we're putting valves in. And when you look to the data set of one of our largest trial, the US trial, they lost 4 patients, and all of those patients developed hours after the procedure tension pneumo. Unfortunately, the US trial started initially as an outpatient trial, and therefore they lost 3 or 4 patients due to that. So nowadays in Europe, we're knowing you have to put the valves in, but you have to take care of the patient for the first 3 days as inpatients, because pneumos can happen. There can be tension pneumos, and those pneumos can really harm the patient dramatically. But we're knowing at the end of the day, patients who developing pneumo, they really have a huge success regarding the volume reduction. You see, these are data from our subsets. When the patient really developing a lot of volume reduction, then they often have a pneumo. So we're knowing that the pneumo is our major complication, but we're also knowing that our pneumo is a predictor of success. So this is something we're debating that in detail with the patients up front. And we're knowing that we really can change the life expectancy of our patients, putting valves in. The green line are those who have underwent the treatment successfully, developing an atelectasis, and you see a 5-year survival rate from nearly 67% compared to those who have been not treated successfully. Now atelectasis, the survival rate was 42% after 5 years. So it clearly shown that the valves changing the mortality. So it's one of the first technologies in our hand that we really can change the life expectancy of severe CBD patients suffering from this phenotype of emphysema. So what are the other technologies? The other technologies are the coils, more used in patients having an RV above 225%. That is a technology which is independent from the complete fissure situation. It's a bilateral technology. This is how it looks after exact placement. And actually we have 3 really trials and 1 registry showing that it works. Unfortunately, the technology have been stopped in the development by the company. So actually we're working with another coils coming from China. Yeah, we do not really have good data, but it has been shown that the coils has the theory technology really working, and also we knowing that we have, when we selecting the patient in a proper way, also first signals that we can change the survival rate of those patients. So coils even not longer on the market. We have to see what happens to the Chinese coils. These are patients who have undergoing the coil 0.2, so the next generation, we have to see what the data are. And there are also 2 other technologies which we can use, and where we're using a completely different mechanism of action. We're injecting steam or vapor to at least bringing the patient in a localized controlled inflammatory reaction in the area of the hyperinflation, and putting that in the lungs, we knowing that that inflammatory process leads to a fibrotic changing, and the fibrosis is reducing the lungs again. Here we have 3 trials, smaller population, also showing that it works. Actually, the bigger multicenter trials are on the way, so we will have better data on that in the near future. So coming slowly to the end, what we need to select the best patient for our technologies, we have really to look to the residual volume, and these are the data of the responders of all larger trials, and you clearly see most of the patients are in the 60s, the FEV1 is around 30%, and the 6-minute walk test is around 300 meters in those patients. But every patient have had an RV above 200%, so we're really knowing our technology only working when we are selecting the hyperinflated patients. And due to the reason that we have now different types of emphysema patients and we have different technologies, it makes a lot of sense to debate those patients in emphysema boards. And for Germany, this is a regulation of by the authorities that every patient has to present to an emphysema board to select the best technology for the best patient. For sure, when the patient has more Buddha's disease, the surgeons are for sure the best option. Also, paraseptals, these are more candidates for lung volume reduction surgery. Lobolea or centroactionaire, this might be the better patients for the endoscopic technologies. So therefore, I believe for having the best patient selection, we have NKT requirements with the surgeons, with the radiologists, and these are my both colleagues, Professor Winter, Professor Heusel. We have our meeting every week, and the German recommendation are that you have to debate about 1,000 patients per year, that you have enough patients for really the volume reduction technologies that you can keep your confidence level high. Why we believe in it's important that it should be done in so-called emphysema centers, because nothing happens without harming our patient. You see here complications, severe pneumo, coils which are migrating in the pleura. So all those can happen, and therefore you need the experts in the hospital. You need a team who takes care of those patients before and also after lung volume reduction procedures, because when you only have one technique, then it's maybe just like Mark Twain mentioned, when you only have a hammer, always everything looks like a nail. Therefore, I want to summarize my talk. I think we have nowadays effective technologies for our patients suffering on lung emphysema. For the valves, we have actually the highest evidence, but we have to select the patient best together with the radiologist and the surgeons. Therefore, the radiology plays initially an important role, but the MDT is for me a minimal requirement, because at the end, patient selection is the most important point. And therefore, I want to thank you for your attention, and I'm looking forward to your questions later. Thanks a lot.
Thank you very much, Felix, for that excellent talk. And Felix will be available to answer your questions at the end in the Q&A session. So please make sure you submit your questions. And also there's a live poll to rate the presentation. So in the next talk, it gives me great pleasure to introduce Jonathan Bennett, who's a respiratory physician from Glenfield Hospital in Leicester, and he's going to give us a talk on what we should do with pure ground glass nodules. And this is a topic that's given us numerous hours of discussions in our MDTs, and it's becoming more and more common with lung cancer screening. So over to you, Jonathan, and thanks very much for attending today.
Good morning, everybody. Many thanks to the Society of Cardiothoracic Surgeons for inviting me to talk at your meeting. Welcome on a bright and breezy Sunday morning. And over the next few minutes, I'm going to talk about those frustrating things called pulmonary nodules, and specifically the hazy, crazy ones, or the ground glass nodules. I should state that I have no declarations of interest, and other than the fact that it's been a crazy year, and I'm hoping that you can recognize your recently refurbished theatres down at the bottom left. What are we talking about? We're talking about ground glass opacities and subsolid nodules. Ground glass opacities are defined here. Descriptive term referring to an area of increased local attenuation on CT with preserved bronchial and vascular markings, very non-specific. Subsolid nodules are essentially the same, but with a small area of solid component in them. You should be aware that the overall malignant potential of subsolid nodules is considered higher than comparatively sized ground glass opacities or non-spiculated pulmonary nodules. There's a wide differential for ground glass opacities, and I've subdivided them here. And we'll be aware that the most common ones that we've seen in the last 12 or 15 months have been viral COVID-19. However, there are still several other chronic and acute illnesses which can be associated with ground glass opacification. But from our perspective, we're more interested in looking out for those with a malignant potential. And we can divide these pathologically into atypical adenomatous hyperplasia of the lung, adenocarcinoma in situ, minimally invasive adenocarcinoma, and lipidic predominant adenocarcinoma, previously referred to as bronchoalveolar cell carcinoma. I hope that we can agree that therapeutic surgical intervention is not routinely required for the benign processes listed. I accept that we may be doing diagnostic surgical procedures, but not usually therapeutic surgical procedures. However, we do need to know where lives are being saved. And this is predominantly for those that have significant malignant potential to cause ongoing harm and be life-limiting. For the vast majority of people, this doesn't include atypical adenomatous hyperplasia. And the jury is still unclear as to what to do in patients with adenocarcinoma in situ and minimally invasive adenocarcinoma. But we do want to take out lesions that are lipidic predominant adenocarcinoma. So how can we define this further? So adenocarcinoma pathologically is defined as a small tumor less than or equal to 30 millimeters in maximum diameter. Usually solitary, but not exclusively, pure lipidic growth with no evidence of invasion. Minimally invasive adenocarcinoma is defined pathologically again as a small tumor less than or equal to 30 millimeters maximum diameter. Often solitary, but not exclusively so. Predominantly lipidic growth with the invasive component less than or equal to 5 millimeters in the maximum diameter. And we can see this defined on this table. So between 6 and 30 millimeters with no solid component is CTIS. For those with less than 5 millimeters solid component and 30 millimeters maximum ground glass opacification, less than, we call that CT1MI, minimally invasive. And I've represented this as a flow diagram here. Just need to be aware that these lesions can be very indolent, slow growing, and you'll have seen this at many MDTs. Some patients may die with them rather than from them. And thus, I hope I can persuade you that the magic numbers are greater than 30 millimeters for pure ground glass opacities, taking us out of the CTIS category, and greater than 5 millimeters solid component for SSNs, taking us out of the MIA categorization. But we're also aware that many of these lesions are not solitary, and it's increasingly common for us to see multifocal ground glass opacities, subsolid nodules, or a mixture of the two, or even with solid nodules. For the multifocal lesions, there's a similar pathology to the solitary GGO or SSN. And the ground glass and solid components seen on CT generally correspond again to the solitary lesions. However, the relationship of these multifocal lesions to one another is unclear, and clonality studies comparing multiple tumours in the same patient are conflicting. But what we do know about these patients with multifocal GGOs is that they have decreased nodal or systemic spread, increased risk of further subsolid cancers, and are often indolent. They're often seen in patients who are female non-smokers. So what impact does increase in the number of lesions have on things such as the Brock score? Limited. And I hope I've demonstrated this here with Brock predictive scoring for a 65-year-old male with an upper lobe 12mm nodule with no evidence of emphysema. And this is the probability of lung cancer according to morphology and number. So slight reduction as we increase the number of lesions. So how do we address patients with multifocal lesions? We essentially review the largest lesion. So it's the highest T stage. And with this, we treat the largest nodule independently. However, it is still unclear as to exactly what to do with these patients. And I would suggest that there are even surgical questions which remain unanswered. What should the extent of surgical resection be? Should it be adapted to the size of the invasive component or only to the whole tumour size? What are the safe resection margins for these lesions? And which nodal dissection is required? Should it be adapted to the precise location of the tumour? All of these questions are still unclear. So with that, I'd like to end short and sweet. I'd like to thank the rest of my team that I work with at Glenfield, the lung cancer team as demonstrated here, and I'd like to thank you for your attention. Happy to take questions at the end of the session. Many thanks for your time.
Thank you very much, Jonathan. That was excellent. Ladies and gentlemen, at the end of this presentation, there'll be a live poll to rate the presentation, so please use that. I have the pleasure of introducing Mr. Joel Dunning. We all know him as a consultant thoracic surgeon at James Cook University Hospital, and he will speak to us about, the site and number of ports. Do they really matter in thoracic, in Vats lobectomy? Ladies and gentlemen, Mr. Joel Dunning.
Hello, my name's Joel Dunning, and I'm going to talk to you about, does the number and site of ports matter? And really, at the absolute heart of this is what is important. So if you're talking about patient clinical outcomes, then Eric Lim's and the UK's Violet study really is going to give us the answer, and gives us the answer. Firstly, it's a phenomenal trial that has proven that we have shorter length of stay, reduced pain, reduced opiate use, better patient-reported outcomes for equivalent oncological outcomes for VATS versus open surgery. Also, Eric is shortly going to give us the results of whether Uniportal versus Multiportal has benefit in the Violet trial. So really, from clinical outcomes, we are going to get the answer. So far, there's been one randomized trial that has been awful between Uni and Multiportal, which didn't say much of a difference. So that's it, really. But Eric will give us the answer for clinical outcomes. But there's a lot more outcomes than just the patient clinical outcomes. So how easy is the operation? Now, this is a really important question because some surgeons are super ninjas, yep, Diego, and other are like me, numpties. So if it's easier, then surely it's safer for us. And also, if it's easier, maybe it's easier for us to train. I personally think it's 1,000 times easier to train on the robot than by Vats. In Vats, I've got to hold the camera as the instructor, and then I'm down to one hand. I can't take over. Robotic, I've got dual consoles. We've both got the same view. I press one button and I'm in charge. A massive difference in terms of training and recording and looking back, and also the training program. It's just phenomenal in robotics. Safety of surgery. Robotics sucks for safety because I'm not by the patient. So actually, if you're scrubbed, then Vats maybe is easier. Maybe Vats Uniportal has a bigger hole, so you can put a swab down there. What's the answer to that? The speed of surgery. Open's the quickest operation, isn't it? If you need to get through 3 lobectomies, do them open. That's quicker than Vats, and certainly quicker than robotics. Cost of surgery. Oh my God, robots cost a heap, don't they? £2.5 more per patient. Vats is definitely cheaper, and actually, tying with suture is the cheapest of all. So it all depends on what matters to you, which is why we have so many different ways of doing it. I think we can all agree, and the violet really shows us that open is not the answer for anything really, other than massive, huge, giant tumours and things you can't get out. So what types of other surgery are there? Well, this is 3-port posterior approach. This is what I was trained on in Edinburgh, a really nice, good, safe way. It simulates the posterior thoracotomy approach because you stand behind the patient. You get a great view. You've got 3 ports in, lovely jubbly. I changed to 3-port anterior approach, and most of Europe does 3-port anterior approach. It was taught to us by René Pettersen and Henrik Hansen in Copenhagen, and it's called the Copenhagen 3-port anterior approach. Super cheap, super easy, nice and safe, good safety steps, really, really good. Uses a load of open instruments, so actually it's pretty cheap, really reproducible, pretty good to train, and so that's great. Diego took over the world with uniportal surgery, and now I think about 40% of the world do uniportal Vats lobectomy. And really he did this through YouTube, through social media, through enthusing people, for creating a community. And as he says, he can do any of these. I can't do half of these things, PA reconstructions, but I can do a uniportal Vats lobectomy pretty okay. It's a nice way to do things. As things get more difficult, sleeves and things like that, it can be more tricksy. But you know, that is uniportal surgery. But a lot of people think, well, the argument is just uniportal versus 3 ports. Complete cobblers. There's so many different ways of doing things. This is the sub-Xiphoid uniportal approach. I think a massive step forward for pain for a patient. You do need the right kind of a patient. This is a right-sided approach. They have to be relatively thin, but it's really quite easy to get in the chest through a sub-Xiphoid approach. Here's Zhang Lei in Shanghai, taking out the Xiphoid. You've got a lovely big hole. You put your camera in, nice big 10mm camera. There's the lobe. You can see it pretty well. There's the lobes. You can see the fissure. There's the diaphragm and the pericardium. It's not bad in the way. He's got some really nice long instruments. These instruments are actually 45 centimeters long, nearly ½ a meter long. But the advantage of that is that then he doesn't clash. Look, his hands aren't clashing here. He's nice and controlled. We're all looking at a screen where the anaesthetist normally stands. Certainly looking at the screen is far prettier than my anaesthetist, that's for sure. And look, you can see the vessels. It's a nice approach. It's calm. It's controlled. So what about it? So it's not just the approach. It's just not the number of ports. It's also where you put those ports and how you do it. You can get around vessels. You can do your firings through this approach. So it's not just a binary how many ports. So I use 4 ports. A lot of people are like, what, 4 ports? What the hell's going on here? But these are 3 5mm ports, and I've got a sub-Xiphoid port because I couldn't quite replicate what Zhang Lei did. But 3 5mm ports, surely the question isn't just how many ports, the question is how big are your ports? And I've also got a camera holder here. I've got an assistant. This is a very comfortable approach. Also, where are your ports? This is Marian Zielinski in Poland. This is a cervical incision. And look at this view. There's the diaphragm. There's the ribs. He doesn't go between any ribs. He's got a great view. But the really important thing, he's done the most phenomenal lymphadenectomy. There's no other better lymphadenectomy than using a cervical approach. He started by doing Temler and Vamler, complete mediastinal lymphadenectomy. But actually, when he got into the chest, he realized this is the truncal branch of the right upper lobe PA. He's tying it with sutures. He's not even stapling. This is super cheap, super safe, and the best lymphadenectomy. So if what's important to you is the best lymphadenectomy you can do, it's cervical approach uniportal lobectomy every time, because you can get out all the N3 nodes, you can get out the N2 nodes, and he's actually done lobectomy on the left as well as the right. I mean, phenomenal approach this is in the right people. You can hybridize your approaches. You could have 2 ports, but keep them both subxiphoid and subcostal. If, as I do, I believe that subcostal and subxiphoid is less painful than any intercostal incisions, but you don't think that you can do it all through a uniportal subxiphoid approach, then put a couple of ports in. And Karel Flirty, I think he's called it in France, does this, and he's very evangelical about this. He's got a lovely system. You can use your normal Alexis ports. You don't even need CO2, and you put your camera in one, and you get a beautiful view, a view every bit as good. Remember I showed you that 3-port approach at the start? There it is. It's really great. You can also hybridize the instruments you're using. So I'm just using 5mm ports, but I'm using wristed instruments in the chest. Here's 2 5mm ports, 3 5mm ports, a camera holder. I'm controlling the camera through my head incision, and these are 5mm ports in the chest, kind of trying to emulate what a robot does. So I'm trying to, all the advantages of a robot are wristed instrumentation and having control of your camera. So you can hybridize this when you're choosing how many ports to use and how big the ports are. We've got wristed instruments, so you can have 2 wristed instruments in the chest if you like. So 2 wristed instruments, they're actually 8mm. I used a 10mm port, and this you don't have to. And this looks like a robotic approach, I think. You've got wristed instruments. Sorry, this is a horrible camera because it was a 5mm one. But look, you can hybridize what you do through 8mm ports. So you've got 5mm, you've got 8mm, you've got multiport, you've got uniport. How are you going to choose? Well, here's something that makes your life really, really easy. But look how many ports it's going to use. It needs 4 robotic ports. It needs a utility incision as well. So this is a 5-port approach. But it's gorgeous. Look at it. It's so easy. You get this beautiful big thing that holds 4 instruments, including the camera. We're using subxiphoid utility incisions for the assistant. We take out the sample subxiphoid, put the drain in subxiphoid. So for me, 5 ports is not a bad approach if you're going to use a robot. But this is all taken into consideration. So what else is out there? Well, Cmr Surgical, the Cmr robot is the new British robot, and it's going to use 5mm ports. So this is a 5mm allied medical ports, a 10mm port for the camera, and then I'm going to use a subxiphoid port, but they're using a 10mm utility incision. You could use 4 ports if you wanted, but again, deciding what's important for you is what might be important. So this is a robot. If you don't like big ports in the robotic view, you might be able to use 5mm ports this way. And certainly the surgeon that's doing this first is a guy called Sven Seifert in Chemnitz in Germany. And he is going to very soon, he's going to be doing lobectomies, but also he wants to use a subxiphoid utility incision. So he'll have 1 10mm port for the camera, 3 5mm ports for the robot, and a subxiphoid utility incision. If you ask me what's the answer, here's the answer. It's just the answer. Let's finish here, because the answer is the intuitive single port system. It's got a 2.5 centimeter port. You need 12 centimeter length to get into the chest. So where's that going to be best? Well, that's going to be best subxiphoid uniportal. I've just showed you it's not that difficult to get into the chest subxiphoid, and it isn't. I've flown to San Francisco and I've done a right-sided lobectomy, a left-sided lobectomy, and a thymectomy, all subxiphoid uniportal. Yes, in a cadaver, but it's going to be just as easy in any human? And this is just going to be the answer. It's a slam dunk answer. It's going to take about 5 years to get going. They've just got FDA approval for use of clinical trials in humans. But Daniel O, Catherine Moore, Mariam Curet, Brian Mitzman, we're all super excited about this as an approach, and we're setting up the Xiphoid Uniportal trial, probably first in thymectomies, because it's going to be a slam dunker in that one. But once we start using it in the chest, I had the best view of the station 7 subcarinal station when using this device, and the answer to why it's so good is in this, which is the snake camera. This can look to the left and it can look to the right by about 30 degrees. So you can look round the lung. So you can go round the hilum to the back to see the subcarinal stations. You can bring all your 3 arms around the back. You can put one of your arms up above your head to push the lung away as you curve round. The disaster of Zhang Lei's technique of the Xiphoid Uniportal is that he can't get to the Xiphoid station. It's a catastrophe, especially on the left. But with this robot single port Xiphoid, it's simple. It really, really is. In terms of technical, how we're going to get the port in to get in the chest, initially we might put a 5mm camera in just in the chest just to inflate with CO2, and then that makes it super easy because it pushes the diaphragm down. But actually we're working on maybe using a mediastinoscope to burrow your way into the chest, or we're going to try the endoscopic vein harvesting system because it's got a camera and the tunneler. So we'll tunnel our way into the chest, get the CO2, push the diaphragm down. And I've routinely used a Xiphoid port into people of BMIs up to about 40. It isn't a problem, not at all, because once you're in the chest, it's a piece of cake. So the only barrier to this is getting in the chest initially. We've got the answer to it. You're going to staple around the side of it. It's a Xiphoid Uniportal, and that to me is the answer. But the answer's 5 years away. So those are my thoughts on how many ports. I didn't show you any science, and the reason I didn't show you any science is because however many papers I can show you, Eric Ling's going to kick my ass because he'll show you the science. We already know Vats is a slam dunk smash better than thoracotomy, so we just shouldn't be doing thoracotomy, and the Violet trial has knocked that one out the park. Eric then will show you the uniportal versus multiportal, and that will include our microlobectomy approach and the 3-port Copenhagen approach, because that was the approaches used in the Violet trial, study of 500 patients. And then you just have to decide for yourselves whether you feel the other advantages of robotics in terms of training and ease of use are right for you. And in 5 years' time, we'll have Xiphoid surgery by a robot. So those are my thoughts. I'm sure you've all got loads of thoughts. But as a final thought, do we all drive the same car? No, we don't. Why haven't we all decided that a Ford Escort is the right car to drive? The answer is because we all have different balances. Maybe where we're driving to is the clinical outcome. So in terms of a patient-centered outcome, that's how do we get somewhere? And actually, all cars can get you to your destination at 70 miles an hour, really, can't they? So it's all about how much we enjoy getting there, how much we can teach others to drive there. And so I leave that thought with you. So I'm out of time. Thank you very much for listening.
Well, thank you very much, Joel. That was an excellent presentation. And now we come to the Q&A session. Still time to submit questions. I'd also encourage you to fill out the poll regarding the previous presentation as well. And as I said before, although unfortunately Julia Veronesi cannot join us for the Q&A session, we're really lucky to have Sasha Stamenkovic, sorry about that, Sasha, who is the Director of Thoracic of Robotic Surgery at Vats in London. So we have some questions that have already come through, but as I said, if people could actually carry on submitting their questions, but we will press on. So first of all, the first couple of questions really relate to Professor Hirth and relate to, is Professor Hirth with us for the questions? He was earlier. Yes. And we have a question that is asking, when you consent patients for valves, what percentage of success or responder rate do you quote?
Yeah, thanks a lot. And again, thanks a lot for inviting me to your excellent meeting. And it's always a pleasure to listen to surgeons, what they're doing next. So to answer your question, be knowing from our own data that we have a success rate actually of 80%. But we went through 15 years of getting experience to that. So therefore, every new center who will start, they have to look to their own data, and then they can promise that to the patient. So we have 80% success rate, 25% pneumo rate.
Thank you. Thank you. And you've got a couple more questions as well. Do you feel that coils are going to make a comeback, is a question?
Yeah, the coils is a little bit the story we have seen a lot. A little startup came up with an idea, and then the big company take it over and decided the niche is too small, and they stopped the development. What we're realizing, and we have seen a couple of movies from China. We have now the Chinese coil. So I think in the future, a lot of new technologies will come out of China. We learned a lot which patient is the ideal candidate for the coils. So therefore, sure, there will be a niche for the coils as well, but it will not be the device we used in the initial phase.
Thank you. And I mean, just from my own personal question, I wanted to ask you, you mentioned about how you monitor patients when you've put endobronchial valves into patients, because obviously of the risk of pneumothorax afterwards. And you mentioned, I think, 3 days. I was just wondering how that compares with when you've used vapor or steam in patients, or when you've inserted coils in patients.
Yeah. So therefore, what we learned from all the trials we're doing on obstructive lung disease is putting a scope in such a patient. Whatever you do at the end is producing a so-called bronchoscopy-induced exacerbation. We have seen that in sham-controlled trials, when you just put the scope in and do nothing, there is a 20% risk off. So we have the patient always on IV antibiotics and 3 days on corticosteroids. So most of our patients staying there for 3 days, because the FEV1 in those is below 1 liter. Most of them are on oxygen, so we don't want to send them too fast home to create problems at home.
Brilliant. Thank you very much. We have got a few further questions as well.
Not for me, thank you.
We do have a question for Dr. Bennett, and that relates to, what do you feel that the role of navigational bronchoscopy or a hybrid lab would be in the role of diagnosing those GGO lesions that you were talking about?
Well, you could probably extend that question to Felix as well, because he'll have done a lot of navigation bronchoscopy. But I suppose the difficulty that you have about sampling these lesions, well, sampling these lesions is that you've got sampling error in terms of you've essentially got radiological assessment of a pathological process. And so if you've got mixed areas, say subsolid nodules, you may not be getting the invasive component. And if you confirm that they've got adenocarcinoma in situ, is it going to change your management strategy for a 20 millimeter ground glass opacity that may or may not have grown over a period of 2 years? So I think that it potentially has utility. I would think that the utility is more for solid nodules than ground glass opacities. But Felix may have an opinion, because he's done lots more navigational bronchoscopy.
Yeah, I developed a couple of those, and we have heard a lot of robotic system. We also have now the ION, so the intuitive endoscopic robotic system. So I'm relatively sure that there is also a huge need for navigation systems for the endoscopic teams. At the end, it's always a little bit patient selection. When I always make it personally, when I would have a PGO where I have solid lesion, I would not go to a bronchoscopy. I would look directly for a surgeon, just resect that. But maybe in 20 years from now, having pure lung function, having a couple of comorbidities, I would be happy that somebody is pre-diagnosing if I have to undergo a surgery. So I believe, and I think we have talked about costs. Even navigation bronchoscopy are super expensive. And the question is who's reimbursing that. So I hope that for lung cancer as well as for obstructive lung disease, there is a team, an excellence center where all disciplines working together and they're deciding what is best for the patient. And for sure, there are patients who need navigation bronchoscopy.
Okay, thank you very much. And then we've had a question also actually regarding if a patient was to have a 50-year-old female was to have a part solid GGO of 3 centimeters, but with a solid component thought to be in the region of 4 millimeters, what do people think, treat versus surveillance?
Well, you're on the cusp there, aren't you?
I think that's why they've gone for those dimensions.
Yeah, thank you. Yeah. You have a discussion with the patient. And then it's in a way it's patient choice, because you can't give absolute answers in that situation because we're still learning about these things. So I would say it's a discussion with the patient. Obviously, a 50-year-old, I think you'll end up probably, depending on where it is it really central? Can you get away with a sublobar resection, etc., etc.? You probably pitch them for going. You probably pitch them for going for a surgical resection. Felix.
Yeah, I think even in running now in the age of lung cancer screening, what we shouldn't forget, we only looking for outcomes and morbidity, but I always call it living with a nodule. So what that means for a patient, knowing that he has a finding and we cannot really forecast what happens for that, is something we have at the moment not in our box. So we really have to focus also, and what is, Jonathan, that you already mentioned, we have to discuss that with the patient, because I think we should have that when we're running to screening, even debating before offering the patient a CAT scan, because we knowing we have a high rate of detection and we knowing most of the patient we don't want to touch, but we have to explain to the patient that they have to live with that there is something in their body we do not really can forecast what it is.
Yeah, I'd say, and we've all met the patients that, I make the patients that say that for even smaller nodules, they can't face knowing the unknown. And so they want it out, whatever. And then there's other people that say, you can tell me whatever. I don't want to have anybody coming close to me with a knife or with a robot or with whatever it is. And I'm more than happy to be put under a scanner and take my risks. And then obviously there's that massive group in the middle which essentially say, what do you think, doc? And you then have you say, well, depending upon which way they pitch, you say it's probably best to go and have a chat with your friendly surgeon, because they will be able to tell you what their local outcomes are, risks, morbidity, etc., etc.
So thank you very much for that. And I think we should take advantage of the fact that Sasha has joined us to answer some of the robotic questions. So we've had a few robotic questions coming through. One of them is, what advantage do you feel that there is an advantage between rats and vats when it comes to defining intersegmental planes? Because obviously everybody's moving towards doing sort of more segmental resections. But do you feel that rats has that advantage over vats in terms of defining those planes? Unfortunately, Sasha, I don't think we can hear you. Okay. Okay, we don't seem to be able to hear Sasha at the moment, so we will move on to the questions. We've had a question again for Professor Hirth. Just, I think again, it's relating to the consent side of things, and just expanding really in terms of your survival, what you feel is really the survival benefit when it relates to endobronchial techniques and lung volume reduction surgery.
Yeah, you see, we published our data already, having the 5 years survival correlation between those patients. Really, we were able to show that in the CBD cohort, we really can improve the quality of life, and we can change the morbidity by having a better survival when the patient has had a successful treatment. This is similar what the surgeon showed in their NET trial at the beginning of 2000s and then the follow-up. So therefore, as pointed out in my presentation, the decision which might be the best technology for the patient should be made in multidisciplinary team approach, because there are clear patients who are benefiting from the surgical procedure, and the surgery developed a lot in the last 20 years. So you cannot use the mortality or morbidity data from the NET trial anymore because it's minimally invasive, it's Uniport or whatever. Therefore, I believe you should decide in the team which is the best technology for the patient, and then the discipline who offers that should talk with the patient about complication and expectations.
Thank you very much. Sasha, have you managed to join us yet? There's quite a few robotic questions coming through for you. Okay, let's find another one while we're waiting to sort out that technical issue. I suppose though this is a more like general question actually that we can think about, because obviously there are different robotic systems as well available, but also should we as a society, the SCTS, should we work together to try and reduce the cost by sort of the different competition between the different companies? So we can, looks like Sasha's joined us, but we could have that as a discussion. Sasha, can you hear us? Could you just speak for us just to...
Can you hear me?
Yes, we can. Yes, we can.
Yeah,
Thank you so much. Thank you so much for joining us for this Q&A session. We've had quite a few questions that have piled up for you while we've been waiting for you to join us. A few questions. When do you decide to perform a VATS or an open procedure as opposed to a robotic procedure? That's one question that's been asked.
Well, that's an easy one for me because I got access to the robot whenever I wanted it. But I appreciate that's not easy for everyone else, and that is a real dilemma. But I think what we've got in our department with 5 robotic surgeons with equal access to the robot, we're finding that some of those surgeons are doing Vats Segmentectomies, but those same surgeons are doing robotic segmentectomies. And the world is turning, and we are definitely moving towards segmentectomy. Every year we're doing more and more segmentectomy. And I don't wish to steal David's thunder later on in the day, but I think that's what he will be saying. Sublobar resection is what we're going to be seeing in the next 5 years.
Brilliant. And actually related to that sort of move towards segmentectomy, we'll come back to the question that when we first encountered the technical problems, do you feel that RATS has an advantage over VATS when it comes to defining those intersegmental planes?
Absolutely. The fluoroscopic camera that you have with all the 4th generation robots gives you the access using ICG. And we've done this either way. Before COVID, I was doing it endobronchially. So I was defining before the operation where the segmental bronchus was and injecting green stuff down that. And since COVID, and we weren't allowed to do bronchoscopies for the aerosol problem, we've moved on to uniformly as a department doing intravenous ICG. It doesn't stick around for long because first pass is quick. So you have to inject C under your what's called Firefly camera, burn little dot to dot way around the segment as you see it, and then within 5 minutes it's gone again. It's vanishing. But it gives you really, on the whole, very, very well defined intersegmental planes to follow. Now that comes with robot, and I appreciate you can probably get an ICG, and Dominic certainly has access to that, fluoroscopic Vats camera, but it's all in one package with the robot, and that's why I like it.
Excellent. And just going back to those intersegmental planes, what's your view on intersegmental margins for sub 2 centimeter lesions that are close to that intersegmental plane?
Yeah, we argue this and debate this constantly in our department, because if you think of the middle lobe as a segment and you have a lesion on the periphery of the middle lobe, you're not going to take the lower lobe with it or the upper lobe with it if there is a decent fissure or a decent plane. And so I don't know whether we're going to get more information after the Japanese trial, but we would say that margin is a difficult one. And so we've moved on to a fusion technology thing. So if we feel that we are going to be in between two segments, two planes, then we would put a fiducial in. So we've got the benefit of Kelvin, obviously, with navigational bronchoscopy. We've done a few procedures now combining fiducial and robot and using other technology to give us a better margin. We've had patients who've come to us and asked for margin. They've been reading the literature, and we're trying to define that for them by using as much technology as possible.
Excellent, thank you.
Can I ask a question about the cost of the robot? Of course, we know and we see the benefit that we may have using a robot. Do you think that in the future there will be a reduction of the cost, and B, also from the NHS point of view, for example, here in UK, a recognition and therefore an increase of the tariffs for robotic procedure versus VATS or normal procedure?
So the second question, we are constantly in contact with NHS England, quite conveniently being placed in London. We have the ability to knock on doors easier. It doesn't mean we're getting anywhere, but they're definitely listening to the story that robotics has taken over nearly 50% of UK and Ireland thoracic surgery in one form or other, and therefore tariff has got to change. I haven't got a direct handle on that, but I think that's where it will go. The first question is about the cost of the robot. There's the cost of the disposables and the cost of the actual robot. So the disposables have been met by what's called an extended use program that Intuitive have brought out. They believe their materials are lasting longer and safer, assuming we treat them properly. And therefore, that should reduce the disposable costs. And as regards the cost of the actual robot, majority of people in the UK are sharing a robot. Joel himself is sharing robot with the rest of his colleagues, multi-specialty. So the cost of the robot, the cost of the maintenance contracts is then shared between different budgets. I don't think over a 10-year period that becomes really less of the problem than the disposables.
And we've had another question sort of related to that, which was basically asking about the other robotic systems, what robotic systems that you know of that are coming to market apart from obviously Intuitive and the Cambridge robotic system.
So we've obviously looked at Versius. We've been up to Cambridge. It's an interesting machine. It's modular, which is different to the way Intuitive have things. It doesn't have the future-proofing for SP, which is what Joel's waxing lyrical about. And when I saw SP 3-4 years ago, I was absolutely amazed. And I've been sub-Xiphoiding for quite a while, and I can see there's a huge benefit in that. So modularity is coming from Versius, and by modularity I mean you have different arms on trolleys, so completely separate. The question is, how well connected are they? What is the safety? I don't know any of that because it hasn't been put into clinical use. I can say that 8 years now in robot, it's not the robot that's made the mistakes. It's the person on the end of the robot that's made the mistake. So I think you've got an incredibly safe situation with good communication between arms with the intuitive offering. Medtronic are coming out with a robot. It's going to go through the CE rather than the FDA approval process, and that will be coming out, and that's probably going to be modular as well. And I haven't seen anything from Johnson & Johnson and Google, which was something that we all went to a demonstration in London, and that's sort of being kept quiet. I don't know what's happening there.
Okay. We don't have much time left. In fact, I think we actually have come to the end of our question, and there's still lots of questions that people are wanting to ask. So maybe there'll be the opportunity in other sessions. But I just want to thank very much all the speakers for excellent presentations, and also the participants for, again, interesting and thought-provoking questions. So thank you very much, everyone.
Thank you.
Thank you
very much.
Thank you.